the next table is with experts. So I have the honor to come to the podium. Professor Kuhn is already known from previous presentations. Welcome again, Professor Kuhn.
Yes, thank you very much. Thank you again for the kind invitation and for discussing another urgent topic with you, the comparison of different X-ray staging procedures following neoadjuvant chemotherapy for in CN plus patient converting to CN0, comparing sentinel node biopsy, targeted X-ray resection, and marking lymph node biopsy. So these are my disclosures. So with neoadjuvant strategies, the conversion rate of lymph nodes in primarily node-positive patients is high, more than 50%, as we have seen in the AXANA study. And this is up to 76% of the KEYNOTE study for triple-negative patients with the use of checkpoint inhibitors. So I think one thing is very clear, that treating these patients with axial resection would overtreat many patients. So we need less invasive procedures. There have been many studies ongoing during the last decades addressing the accuracy of sentinel lymph node biopsy after neoadjuvant chemotherapy, and I think this meta-analysis has already been shown. So for patients who have a negative lymph node status before chemotherapy, the accuracy is fine, so the false negative rate is 3.2%, but we have seen that the false negative rate for patients who present initially with a positive lymph node status is higher than the accepted cutoff of 10% with 14.8%. There were several measures proposed by retrospective analyzers to improve the false negative rate using immunohistochemistry in the SN Canadian trial that could reduce the false negative rate under 10%, the use of a dual tracer, or the removal of at least 2 lymph nodes. In 2015, a new procedure was introduced by Mila Donker from the Netherlands. Instead of looking the first draining node, the largest biopsy-proven node was marked with a seed, with a radioactive seed, a procedure that was called MARI. And with this procedure, the detection rate was high, 97%, false negative rate low, less than 10% by 7%. Now, in the meantime, since radioactive seeds are not available in many countries, many competing techniques to mark these lymph nodes have been introduced, like the use of charcoal suspension, the use of clips, coils in different sizes and shapes, with and without shells, that can then be localized with the use of ultrasound, or modern techniques with the use of magnetic, paramagnetic, radar-based or radioactive seeds that require probe-guided localization. Now, we have already seen this study from Terry, from Abigail Cordell, that was published in 2016, and this study, both procedures, a sentinel lymph node biopsy was combined with a target lymph node biopsy, and it was shown that for the sentinel node biopsy alone, as expected, the false negative rate was around 10%. For the target lymph node biopsy alone, it was 4.6%, and for the combination, it was very low, around 1.4%. And as already has been pointed out, 23% of the target lymph nodes were not sentinel lymph nodes, and 6 patients with a negative sentinel lymph node had a positive target lymph node, showing that the target lymph node detected positive lymphs that would not have been detected by the sentinel lymph node procedure alone. Again, this was the false one. Now, in 2021, we conducted a survey asking European surgeons, so what is your preferred procedure? And for patients with a CN1 status with 1 to 3 positive lymph nodes, targeted X-ray resection was the preferred method, followed by sentinel lymph node biopsy, although still many surgeons performed axial lymph node dissection. For patients with CN2, so more than 3 involved lymph nodes, axial lymph node dissection is still the standard for many surgeons, followed by target axial resection or central lymph node biopsy. Now, what is the distribution within the Axana study, where we accept all procedures, and in the end, we will compare the procedures with regards to outcome, to life quality, and so on. So the majority of surgeons prefers target axial resection. There are still many surgeons performing lymphadenectomy, but in some countries, central lymph node biopsy is still the standard of care, and in some countries, they require 2 or more central lymph nodes, in other countries not. In other countries, a simple central lymph node biopsy without dual tracer, without requirement of 2 or more lymph nodes is accepted. So countries where central lymph node biopsy is the standard is Turkey, Peru, Italy, Norway. I think in Greece it's 50-50 when I looked into our charts. And especially in Italy, surgeons do not rely on 2 or 3 lymph nodes. They just perform a simple central lymph node biopsy, single tracer, and 1 central node is enough. And we want to compare all these different procedures within the Axana trial. So if you want to compare of the technique, central lymph node biopsy, marked lymph node biopsy, or target axial resection, we have to look at the accuracy, the feasibility, outcome, surgical extent with regards to number of resected nodes, the impact of life quality, and certainly costs. Now, regarding false negative, the 10% is an arbitrary cutoff, and we do not know how this translates, how a higher false negative rate translates into recurrences or outcome. There is no evidence if and how a higher false negative rate translates into word outcome, and should we really worry so much about a small increase of the false negative rate? Now, this is a comparison of false negative rates between primary surgery, NSABP B32, and the Sentinel and ACOSOX trial, where the false negative rates after neoadjuvant chemotherapy, node positive patients was assessed. And you can see that in NSABP B32, the false negative rate was 9.8% for all patients, 14% in both trials in the neoadjuvant setting. But we do not know if this impacts recurrences or disease-free survival. And in NSABP 32, the false negative rate for 1 lymph node was 17.7%. And we never discussed removing more than 2 central lymph nodes. But we know that this does never translate into higher recurrences. So should we really worry so much about 14% false negatives? We don't know yet. But what does it mean, 14% false negative? And this is often misunderstood. So if we have a false negative rate of 10%, we have residual disease in 15%, we will overlook 5 patients among 100 patients, because the false negative rate always relates to the number of node positives in the group. In a group, when we have a false negative of 14%, we will overlook 7. So the difference is 2. And if the false negative rate, if the response rate is even higher, as in Keynote 522, there's only 1 patient that we would overlook with 14% false negative compared to 10%. So it's a little bit less than we often think. Now, what about detection? So this is the Sentinel trial, and in the Sentinel trial, we had 4 groups. And at that time, it was from 2009 that we started recruitment. We still looked at sentinel node biopsy before neoadjuvant treatment. And so we had 1 arm where sentinel node biopsy was performed before neoadjuvant treatment, and we had the group node positive after neoadjuvant. And among 100 sites that did the same techniques in every patient, the upfront central lymph node biopsy was associated with a detection rate of 99.9%, while after neoadjuvant chemotherapy in patients who converted from node positive to node negativity, the detection rate was only 80%. So there is something going on. And this may be one explanation. And these are pictures I took in the very early days of central lymph node biopsy when we started with a blue dye. And you see a completely invaded lymph node. And you see the blue stained vessel, and it stops at the lymph node. Why? On the right picture, you see there's no lymphatic tissue. So this lymph node is simply not able to uptake any tracer. And this leads to detection failures, or there may be a bypass. And this is also the reason why very often we have false positive results with ultrasound after neoadjuvant, because we see the fibrosis after neoadjuvant chemotherapy that appears like a positive lymph node. So this is one explanation why we have a lower detection rate and a higher false negative rate in the group of in the sentinel node group. Now this is a meta-analysis confirming now with many studies that the detection rate a bit higher than we had in Sentinel, around 89%. So it is a bit lower. But is targeted axial resection now so perfect that it solves all problems? No, it does not, because we have failures to detect the target lymph node. With the carbon suspension, we have detection of 93 to 95%, which is quite high. Although the problem with the carbon suspension is that you have to open the axilla very widely, so it's a huge operation. For the clip, we have a detection of 77 to 99%, so this is very dependent on the radiologist to identify the central lymph node. And for the seeds, we have quite constant detection rates. Whatever we use, if we use radioactive seed or radar seed or magnetic seed, whatever, around 94 to 97%. And for the use of devices to mark the lymph nodes, we also have a problem with lost markers, with a 7% in the Axana study. Although I have to say, we have 7% of lost markers, but 5.8% are clips and coils which are not detected. So this is a problem associated with target axial resection. Now, what about outcome? And we have several studies. Okay, most of them are retrospective. The observation time is quite low. But what we can see that whatever we do, axial recurrence rate are low and less than 2%. So probably the technique of X-ray staging does not translate into high recurrences, whatever we do. So this is the OMA study, and this is interesting to know what is the extension of surgery, and we all were quite astonished to see that with a central lymph node biopsy, there were more central lymph nodes resected compared to the target lymph node dissection, which is probably due to the fact that in this study, only patients were included who had at least 3 central lymph nodes. So central lymph node biopsy after neoadjuvant chemotherapy is not a clearly defined technique, because some surgeons perform just the resection of 1 node, others at least 3 nodes. So this is not yet clearly defined. So does this impact morbidity? We don't know yet. We will analyze this in the Axana study. Now, what about costs? These are costs from Germany. So we know central lymph node biopsy is associated with €250. Radioactive seed is cheap, but not allowed in Germany and many other countries. The charcoal is cheap, €35. Clip is quite cheap, 110, and the modern markers, magnetic or radar, 250 to €450 are certainly much more expensive. And when we compare central lymph node biopsy alone to target axial resection, certainly target axial resection is much more expensive. So we need some reasons to do this, and this must be a matter of discussion. So in conclusion, there's probably no clear winner between central lymph node biopsy alone, target lymph node biopsy, or target axial resection. There are moderate differences with regards to false negative rate that probably do not translate into oncologic outcome. Detection is an issue for central lymph node biopsy and the resection of a target lymph node. The impact on morbidity is unclear, but costs are also important. So we certainly need further data to examine this, and therefore we have the Axana study that recruited more than 6,000 patients now. We assess disease-free survival, life quality, also health economics. So thank you very much.
Thank you very much, Professor Kuhn. It's a debatable topic, and we hope that Oksana will put some light on this topic with the results. I don't know if someone of the commentators have some comment to do. Please, Professor Karakatsanis.
Yeah, now it works. So there are two issues that I think that we should highlight and are clear from this talk for me. The first one is that until we know that we do not need to do better, as you and I have discussed a lot of times in the past, it's not a matter of false negative, but it is a matter of detection rate, given the fact that if you have a failed procedure, then you have to, per definition, condemn that patient to an axillary dissection, because we do not have the data to say that in the previously node positive, we can just refrain from any procedure if we don't find anything. The other thing has to do with costs. Now, that's a conflict of interest for me because I'm the deputy editor-in-chief in the EJSO, and I got a very nice paper recently from Torsten's group that has to do with the sustainability of wireless localization methods in the breast, and the axilla is not very different. But what I would like to highlight is that the problem with radioactive seeds is not the cost of the device per se. In Sweden, for example, the cost of registration and deregistration, handling and disposition is about 6 times the cost of the device per se. So the most expensive in terms of incremental costs for a taxpayer state-funded system is actually the radioactive seed.
Okay.
Thank you. Maybe a question from the audience? Okay, let me make a comment about the sentinel node after neoadjuvant chemo, as Dr. Karakatsanis mentioned, especially in patients with N2 or N3 diagnosed breast cancer before neoadjuvant, the sentinel node post-neoadjuvant simply doesn't work. So what about this population? There are many patients with N2 or N3 disease diagnosis that after neoadjuvant chemo, especially TNBC disease, triple negative breast cancer, or HER2 positive breast cancer, that convert in negative axilla. All these patients with sentinel node maybe finally have axillary dissection that is unfair. Please, maybe an answer.
I agree entirely with you that we have too little data on the CN2 group. But personally, I think that when we also have to take into consideration the response of the breast. So if I have a complete response in the breast, I think I would not, personally, I would not go if I have a clinical response, and I would rely on target axillary resection in the axilla because this patient would probably undergo radiation therapy anyway. But it's still a matter of debate. We don't have data. And so far, according to German guidelines, it's not yet an indication for sentinel lymph node biopsy or target axillary resection because we need no data. But I think with common sense, I would spare a patient an axillary resection if she had PCR on the breast. But this is a matter of debate.
With all respect, I'll disagree with the opinion that if we have PCR on the breast, we have probably PCR in the axilla. There are publications, even with HER2 positive or triple negative disease, that with PCR to the breast and up to 50% residual disease in axilla, especially in N2 or N3 disease. Maybe in N0 disease diagnosis, the possibility of residual disease in axilla and PCR in the breast is up to 0 to 2%. But in all other cases, N1, N2, or even N3, maybe it's residual disease in the axilla with PCR on the breast. Professor Karagatsounis?
Take the microphone, because they cannot hear you.
Just to highlight something that has to do with the source studies. CN1 refers to palpable mobile nodes. CN2 means matted nodes on the chest wall. So the reason that we are discussing 3 as a cutoff or more than 3 and so on is more or less an extrapolation from the Lucerne toolbox in order to facilitate de-escalation to begin with. But a patient with palpable lymphadenopathy, you should not count nodes on radiology. One palpable node corresponds to at least 4 metastases. We have known that since the middle of the 2000s. That's just an idea. Do not condemn patients from the number of nodes on an ultrasound. It is the clinical stage that matters.
We should crack on. Next speaker is Professor Mamounas from Orlando Health Cancer Institute.
Okay, so let me fix this for a second. So we're going to talk about optimizing risk assessment for late recurrence, as I already alluded to earlier in my previous talk. So we know that estrogen receptor positive breast cancer is a disease that continues to have recurrences for long periods of time. These are the data from the overview analysis showing that about half of the recurrences and about two-thirds of the deaths occur after year 5. And this is well demonstrated. In addition, risk of late recurrence in ER-positive disease has been shown again in a new update of the overview analysis that was published by Penn et al. In 2017. And as you can see here, clinical and pathologic factors at the initial diagnosis continue to be prognostic of risk of late recurrence all the way up to 20 years. These lines essentially don't have any sense of decreasing. The steepness of the curves is very much the same. But what's very interesting also is the original clinical pathologic factors have an impact even 20 years later in terms of how much the recurrence will be. So we know this is a disease that, again, continues to recur for long periods of time. We know that about 5 years of tamoxifen used to be the standard of care for many years, as you see, again, from the overview analysis, in terms of recurrence and breast cancer mortality. And 5 years of tamoxifen continue to have benefit all the way to about 15 years later. And when it comes to studies of extended endocrine therapy, these are the two old studies looking at 10 versus 5 years of tamoxifen. This is the ATLAS trial and the ATOM trial, the original sort of presentations. And as you can see, for both these trials, a late effect of delayed of tamoxifen appeared probably after 10 years. So the 10 years of tamoxifen versus 5, they're better both in the ATLAS and the ATOM trial in terms of recurrence. And also, in terms of mortality, the ATLAS trial also has shown, it's pretty much the only trial that has shown a breast cancer mortality and overall mortality reduction with extended endocrine therapy, as you can see here. Now, of course, tamoxifen has been a drug that we still use occasionally anymore, but the aromatase inhibitors, as you know, have surpassed the tamoxifen, and they have been incorporated in multiple ways. As initial therapy, oops, sorry, let me go back. Oh, that's not easy. As initial therapy, we're superior to tamoxifen, 5 years of an AI versus 5 years of tamoxifen, in a sequential fashion after 2 to 3 years of tamoxifen. And in the extended setting, aromatase inhibitors after 5 years of tamoxifen versus placebo, I'll show you some of the trials, still superior. And nowadays, of course, with ovarian factor suppression, aromatase inhibitors are actually better than ovarian factor suppression and tamoxifen. So we combine them now with ovarian factor suppression. So in one slide, I want to summarize some of the extended aromatase inhibitor trials, because those are the ones that essentially, once we start using AIs, we wanted to see how long we should give the AIs for after the 5 years. And as you can see here, this is the MA17 trial. Initially, this was tamoxifen followed by 5 years of either letrozole or placebo. When this was established, there was a further randomization at 10 years to additional 5 years of letrozole or placebo. That trial showed about a 20% reduction, was borderline statistically significant with a p-value of 0.06. And then we had the B42 trial that included patients treated either with aromatase inhibitor or tamoxifen, followed by an aromatase inhibitor 5 years, and then randomization to 5 versus placebo for 5 years. This is letrozole here. And we saw about a 16% reduction with a significant p-value. The third trial for this group is the DATA trial that actually used only about 2 to 3 years of tamoxifen and then randomized to 3 years versus 6 years of the aromatase inhibitor and did show about a 21% reduction. So this trial sort of, I put it in one box, was shown benefit from the extended aromatase inhibitor trials. But again, here, 3 versus 6, it was significant, but it was only after 3 years of tamoxifen, remind you this. And then there are several trials, as you can see, the IDEAL, the ABCSG16, and the SOLEIL trial, that compared after the combination of tamoxifen, aromatase inhibitors, or the sequence, 5 years of all those, to 2 versus 5 or 2.5 versus 5, or here, the SOLEIL was interrupted aromatase inhibitor therapy versus continuous. And all these trials did not show a significant benefit from the aromatase inhibitors. So essentially, arguing that after 5 years of combined therapy or sequential therapy, you don't have to necessarily extend it to 10 years, but you can probably stop at 7 years. But there was no direct comparison, essentially, of 0 versus 3 years extended endocrine therapy. So now, the overview analysis has looked at extended AI therapy, and what it showed so far is that depending on how you start, you may get a different benefit from extended aromatase inhibitor therapy. For example, tamoxifen followed by an aromatase inhibitor, there was about a 5% reduction in recurrence, 2.8% in distant recurrence, and 1.8% reduction in mortality, which all were significant. But when you have combination or sequence of tamoxifen AI followed by AI, then the differences were smaller, and the only significant difference was in recurrence. And then when you have aromatase inhibitor for 5 years followed by additional aromatase inhibitors, the benefits were even smaller. So I'm showing you this to tell you that essentially, although extended endocrine therapy was found to be of value, the benefits are actually small. So obviously, we need to do a better job to identify who are the patients that actually need extended endocrine therapy and also benefit more from extended adjuvant endocrine therapy. So how do we further optimize the selection of candidates for extended adjuvant endocrine therapy? Well, we can refine the risk of recurrence based on either clinical pathologic algorithms. We can assess circulating tumor cells and circulating DNA. This is something that we are having a lot of interest as of late. And of course, as we discussed earlier, we can evaluate genomic classifiers that predict also late recurrence as much as they predict early recurrence. And some classifiers also predict benefit from extended adjuvant endocrine therapy. So this is the CTS5 developed by Ms. Dowsett, based on the ATTACK trial. It was validated in Big 198. And essentially is a score that includes it's essentially clinical treatment score post 5 years, and it includes age, number of positive nodes, and tumor size in millimeters, and grade. And essentially it's a very simple calculator that you can use at your office. Put the tumor size in millimeters, the age of the patient, the number of positive nodes, and grade, and then it will give you essentially the risk of recurrence after 5 years for the remaining essentially 10 years of total follow-up. And as you can see, this was validated. It was developed in ATTACK, validated in Big 198, showing that you can separate patients to a low, intermediate, and high risk. That's a simple and easy way of doing it. What about circulating tumor cells? Well, this is a paper by Josh Sparano from the ECO group that actually did a secondary analysis of a large study, the B5103, is the one evaluated bevacizumab at the time. And they had 547 patients with ER-positive, HER2-negative breast cancer. They obtained CTCs around 5 years after diagnosis. and they looked for risk of late recurrence. The CTCs were detected only in about 5.1% of the patients, and 6.5% of the patients had clinical recurrence. And having a positive CTC essentially led to a 13-fold increase in the risk of recurrence, as you can see here, much higher recurrence. And about a third of the patients with recurrence had a positive CTC assay result at a median of 2.8 years before clinical recurrence. So essentially, CTCs, and I'll show you next, ctDNA, appears to be a marker that essentially heralds the development of metastatic disease in the next year or two. So this paper from Lipsik Sharf, who now is at UCLA, it's interesting when you see an oncologist who sometimes you may have treated a relative 30 years prior to that. It's getting old. This is ctDNA for prediction of late recurrence, and again, it's 103 high-risk stage 2 to 3 hormone receptor positive patients diagnosed after 5 years and being NED. They did whole exome sequencing of the primary tumor, and then they took plasma at consent and every 6 to 12 months. And to make a long story short, 10% of the patients had positive minimal residual disease assay. 6 patients developed distant recurrence, and all of them were positive for MRD before. There was another patient that was positive that had a local recurrence, but they did not go on to develop distant recurrence. And you can see, of course, things that we've seen now in many, many other studies, that the minimal residual disease leads to a very poor prognosis. And again, when you compare it to at initial diagnosis or at any time having a positive assay, the curves with the any time are always steeper, meaning that if at any time you were positive, you do very poorly, but if you remain negative, then you do better. But at one time, in other words, you're negative and you're okay, but you could be positive a year or two later, right? So you have to exclude these patients. What about genomic classifiers? And as I mentioned earlier today, I think it's fair to say that any of the genomic classifiers that predict risk of early recurrence also predict the risk of late recurrence. Almost similar to what we see in the meta-analysis with grade or tumor size. It's a prognostic factor from the beginning, and it continues to be one. EndoPredict does that, breast cancer index does that, PAM50-ROR, and even the 21G recurrence score only for high ESR1 patients. The recurrence score doesn't work exactly the same for all patients, but only for the ESR1 high patients. But prognosis is one thing. The question is, can you identify who benefits from extended endocrine therapy? And so for that, actually, we have more data. The marker that has the most data is the BCI, the breast cancer index, and particularly the homeobox13 interleukin 17B receptor ratio, or H/I ratio of the BCI. So this was essentially shown in the MA17 trial to predict benefit from extended endocrine therapy. If you have a high H/I, there was a significant reduction with extended letrozole therapy. Low H/I, there was small benefit. It was not statistically significant. The absolute of recurrence was reduced by 16.5% for patients that have high H/I, and the interaction was statistically significant. They then validated this in the TransAtom trial, John Bartlett publication, looking again at longer tamoxifen versus shorter tamoxifen and finding essentially the same thing. For all patients, there was a difference. The BCI H/I high, it was a significant difference, but the BCI H/I low, it was not a significant difference. And as you can see here, in terms of absolute benefit, the overall was about 5%. It was 10% for the H/I high and almost 0% for the H/I low. And then in the ideal trial that I showed you a little bit earlier, these were patients with tamoxifen aromatase inhibitors of the sequence, randomized to shorter or longer letrozole therapy, 2.5 to 5 years. And then 88 of the patients received either an AI alone or the sequence of tamoxifen followed by an AI. And for those patients, the hazard ratio was 0.92. When they apply the breast cancer index H/I ratio, again, this is the overall unselected population. There was no benefit for the low, but benefit for the H/I high. And again, remember, this was for shorter versus longer letrozole therapy. So you could make the argument, if we had the debate between 7 to 10 years, some of these biomarkers at least may tell us which one you should go to 10 years and how much you can stop earlier. And this is NSABP42, which we also evaluated the BCI. And remember B42 had the same aromatase inhibitors or tamoxifen followed by aromatase inhibitors, and then letrozole 5 years versus placebo. When we looked at the overall benefit, was about hazard ratio of 0.77% in the group of patients that were applied the BCI. This is about 2,100 patients from the B42 study. But when you look at BCIH over I high versus low, we did not see a significant interaction. You see hazard ratios with benefit both for BCI high, 0.83 and 0.69. Now, in the B42, there was a little bit of a difference pattern of distant recurrence, what we noted in the parent trial. What we noticed was that there was no benefit from extended letrozole therapy in the first 5 years of treatment. But after that is where the differences in distal recurrence emerged. So essentially, there was a significant non-proportionality of the hazards. As a result, we did a conditional analysis to look at the benefit according to essentially starting at 4 years. In other words, ignoring, so to speak, the first 4 years where there was no difference. And what we found then, it was the BCI high actually patients benefited from year 4 to year 10, but BCI low patients did not, if you did a conditional analysis. But again, this interaction was also not statistically significant, but clearly the benefit here was statistically significant. And then if you look at it according to non-negative patients versus non-positive patients, most of the benefit was seen for patients that have no positive disease, and it was seen for the BCI over I high for 4 to 10 years. Every other category did not have much benefit. And also, when you look at it according to HER2 status, essentially the HER2 new negative patients are the ones who benefited from the extended therapy from year 4 to year 10, and that interaction actually was statistically significant. So not exactly a pristine sort of demonstration of benefit, but nevertheless kind of the same thing. We also evaluated MammaPrint in B42, and essentially the hypothesis there was that MammaPrint high-risk patients would have more benefit from extended endocrine therapy, MammaPrint low would not. But essentially we found the opposite. We found that MammaPrint low patients appeared to have more benefit, which was significant. MammaPrint high patients did have some benefit, as you can see here, but the difference was not statistically significant. And also, this was RFI, distant recurrence here, but we have secondary endpoints, and these were disease-free survival and breast cancer-free interval, which includes contralateral breast cancer. And in these endpoints, actually, MammaPrint low patients had significant benefit from extended endocrine therapy versus MammaPrint high patients. And this was actually statistically significant for interaction. Arguing perhaps that the contralateral breast cancer adds to these events, and essentially saying that if you MammaPrint low, maybe you have more sensitive tumors, and then more likely to get a contralateral MammaPrint low tumor, and potentially you can benefit from extended endocrine therapy. Also, another analysis there was the MammaPrint ultra low versus the MammaPrint low but not ultra low, and essentially most of the benefit happened to the low but not ultra low because the ultra low were so good. Although, again, you can make much out of this because the numbers are very small, but they have very low risk. And then that was the first observation that MammaPrint may be important, but then we had also a report from the IDEAL trial. I remember I showed it to you with the BCI. So the IDEAL trial was also looked at MammaPrint for benefit from extended adjuvant endocrine therapy. And essentially what they found was what we found in B42, that MammaPrint high-risk patients don't benefit from extended endocrine therapy significantly, but MammaPrint low patients do. And this was for, again, distant recurrence as the endpoint. But also relapse-free interval, the same thing. You can see no benefit for the high risk, benefit in the low risk. When it comes to the low but not ultra low, most of the benefit, again, shown in that group of patients that are low risk but not ultra low, where they don't have much risk of recurrence anyways. And again, when you look at significant interactions, these were significant interactions for any of those endpoints. And the absolute differences for the MammaPrint low risk was 10, 11% for any of those endpoints. So this may be real. 2 studies now have shown that MammaPrint does predict the risk of late recurrence. So based on that, what do the guidelines tell us to do? Essentially, for N0 NED after 5 years of endocrine therapy, there's insufficient evidence to use any of these biomarkers because essentially they are prognostic, but they don't help you much with the decision. If you're N0 or N1 with 1 to 3 positive nodes and NED after 5 years, may use BCI to guide decisions for extended endocrine therapy. If you have 4 or more positive nodes, then you should probably prolong the therapy, and there is insufficient evidence to use any of the biomarkers. And again, the premenopausal patients, there are very few, so there's not much treated information for that. In terms of NCCN guidelines, you can see hormone receptor positive T1, T2, PN0, the BCI, can be used to help with the benefit of extended endocrine therapy. And for hormone receptor positive T1 to T3, PN0, PN1, again, use the BCI, offers in terms of risk of late recurrence and benefit from extended adjuvant endocrine therapy based on the studies that I showed you before. Now, there's some remaining questions. After 5 years of an AI, is continued AI better, or maybe we should switch back to tamoxifen, do the reverse? Will some patients benefit from more than 10 years of adjuvant endocrine therapy? Can we go to 15? Will there be any more benefit? Would women who remain premenopausal at 5 years benefit from ovarian factor suppression versus extended endocrine therapy with 5 years of tamoxifen alone? In other words, can you extend the ovarian factor suppression? And will patients who are now receiving adjuvant CDK4 inhibitors, abemaciclib, ribociclib, will benefit from extended endocrine therapy? We haven't answered this question yet. And how will incorporate the new SERDs and extended endocrine therapy strategies into extended endocrine therapy strategies, because all these studies now are using SERDs to evaluate comparing to aromatase inhibitors in the adjuvant setting. So in summary, the extended endocrine therapy reduces the risk of recurrence and contralateral breast cancer in a selected population. It does not significantly prolong overall survival. I didn't show you the data, but essentially none of the studies except the ATLAS has shown a survival benefit. Benefit from extended aromatase inhibitor therapy is larger after 5 years of tamoxifen and progressively decreases after 5 years of the sequence or 5 years of an aromatase inhibitor. And improved clinical pathologic algorithms, circulating tumor cells, and genomic classifiers can help refine the risk of late recurrence and to benefit from extended endocrine therapy. I think one of the remaining questions is, if you intervene at the time that the test turns positive by changing your treatment or extending therapy, would you make a difference? And I think that's a big question that is going to be answered in studies the years to come. Thank you very much for your attention.
Thank you, Professor Mamounas. Any questions from the audience? Any comments? Any comments from our commentators? Thank you very much again.
The next presenter is Professor Vahid, President of Senologic International Society. Professor Vahid.
Good evening, dear my colleagues, dear presidents, chairman of this panel. First of all, I would like to thank the organizing committee for inviting me for this congress and for this beautiful city and country, our neighboring country. And my title is Surgical Management of Residual Disease After Neoadjuvant Chemotherapy. As you know, it's a classical thing to tell. Changing paradigms in breast cancer management changed the breast cancer treatment from radical mastectomy, according to Hallstatt, it was a local regional disease, and then this changed to systemic disease hypothesis by Bernard Fisher. He did many clinical and experimental studies show that it's also a systemic disease. And after that, we accept that breast cancer not only local regional, but also systemic disease. And after 2000, when we found that it has a different molecular subtypes and it's a heterogeneous disease, and we started to change our treatment target to personalized and tailored treatment for every patient. No treatment all size fits for one patient, but we know that we have to tailor treatment for individualized patients. And also surgery, the place of surgery in the treatment of breast cancer has escalated by the times gone by. And then surgery was alone almost more than 1 century, and then it was a radical mastectomy, and then changed to modified radical mastectomy preserving pectoralis major muscle in UK also, and then changed to simple mastectomy by NSABP-B04 trial and showed that there was no overall survival difference between the patients with radical mastectomy and mastectomy alone and mastectomy plus radiation therapy. The study also showed that axillary dissection didn't add any survival advantage to the patients with breast cancer. And then we started to perform personalized surgery after breast conserving surgery plus radiation therapy. There are some studies, ongoing studies, especially from MD Anderson Cancer Center by Dr. Kurer. He started a study to omit surgical procedure in patients with a complete clinical response in the breast after NAC, but false negative rates of vacuum biopsy in these patients was very high, and it's not accepted today. And we know that NAC changed the treatment in breast cancer patients from radical mastectomy to breast conserving surgery. It has been used for 50 years, and in last 2 decades, it has been used so extensively. And in a MD Anderson clinical trial published in 1990s by Dr. Eva Singletary, and it showed that the patients with locally advanced breast cancer and actually they were undergoing the mastectomy had a breast conserving surgery in 25% of patients due to the tumor size reduction and then possible breast conserving surgery. And in addition to taxane-based chemotherapy to adriamycin and cyclophosphamide therapy, the results of the combined NSABP-B18 and B27 trials published by Dr. Mamunas in 2012 in JCO show that PCR rates increased to 26% in patients taken additional taxane, and the breast conserving surgery rate increased to 42%. And how about the targeted therapy? Also immunotherapy added to the systemic chemotherapy NAC of breast cancer after 25, and we found that breast conserving surgery increased over 50% in this patients group. We know that neoadjuvant chemotherapy allows less extensive breast surgery and axillary surgery by downstaging the tumor and allows monitoring treatment response. PCR to NAC is strongly associated with improved long-term survival outcomes, but we don't know about locoregional recurrence after breast conserving surgery in patients after neoadjuvant chemotherapy. There was a multi-analysis and review show that breast recurrence rate is 6.5% over in patients with breast conserving surgery after NAC. And it also plays a crucial role in determining adjuvant therapy in the presence of residual tumor. And we know that from the Catherine trial and CRADE trials, additional adjuvant treatment increases survival in patients with triple negative and HER2 positive breast cancer. Pathologic complete response rate to NAC varies according to molecular subtypes of the tumor and NAC regimen given. As Professor Kuhn showed before, PCR rate is around 5 to 10% in ER-positive, HER2-negative patients. It's between 17 to 33% in patients with ER-positive, HER2-positive breast cancer. It's 36 to 50% in HER2-positive patients. It's around 35% in patients with triple-negative breast cancer. This similar rate is in lymph node conversion rates is around 15 to 20% in ER-positive liminal A patients. Is around 65%. In HER2-positive is 50% in triple-negative breast cancer patients. And now the place of surgery has been de-escalated in patients with poor molecular subtypes breast cancer. One of them is triple-negative breast cancer. Today, upfront surgery only recommended in patients with T1 and 0 breast cancer, tumor size less than 1 centimeter, and also T1B, T1C patients, NAC is recommended and after surgery, but upfront surgery may be considered in patients for selected T1 patients, and T2 patients, Keynote study shows that almost 76-77% of PCR rate, and in this trial, pembrolizumab, carboplatin, paclitaxel, and AC are recommended as a neoadjuvant chemotherapy and after surgery, and additional adjuvants determined by residual disease. In also HER2-positive breast cancer patients, treatment algorithm change. If patient has a T1A and T1B0 tumor, upfront surgery is recommended. In patients with T1C and clinical A0 disease, there is a debate about the NAC or upfront surgery, but if the tumor size is more than T2 or greater, and any clinical tumor with clinical and positive disease should have an neoadjuvant chemotherapy. Surgical management of patients with residual disease. Patients should be evaluated before and after NAC for surgery. Clinical examination is most important step to me. Tumor breast ratio is important to protect, to save the surgery. Before and after, make a decision. And axillary status also important. Every patient should have axillary ultrasound. And biopsy together with immunohistochemistry and marking on the breast tumor and positive lymph node recommended. PET MRI or PET CT in patients with positive lymph node, and brain MRI in patients with triple-negative breast cancer patients recommended. And genetic test is also performed in patients less than 50 years old and triple-negative breast cancer patients. But we can make a decision before surgery in some patients and after this NAC also. If the patient has a malignant diffuse microcalcifications and multicentricity and clinical T4 tumor, and if patient has an inflammatory breast cancer, and also if she has a pathogenic gene mutation carriers, especially for 6 genes, should be considered about the mastectomy. In our patient, you will see that there is a substantial decrease in microcalcification after neoadjuvant chemotherapy, but the patient has a small size of breast, and almost half of the breast had a microcalcification before neoadjuvant chemotherapy. We performed nipple-sparing mastectomy together with implants. If the patient has a single or multifocal tumors, and if she has a good response to NAC, and tumors and positive nodes should be marked before NAC, and negative margin, surgical margins after lumpectomy is necessary. But in a study, margin with less than 2 millimeter or close knowing on tumor versus so margin more than 2 millimeter wasn't found associated with ipsilateral breast tumor recurrence after NAC for breast conserving surgery. And good cosmetics result outcome is very important. We have to obtain good cosmetic results. And as you know, after new modern chemotherapeutic agents and radiation therapy, the life expectancy of the patients increased, and we also need to see a good cosmetic breast in our patients. Sometimes the partial latissimus dorsi flap reconstruction in our patients at diagnosis or after NAC, and I used partial latissimus dorsi flap and preserving its pedicle, vascular pedicle, and I use the same incision from axilla to remove the tumor, to check the surgical margin of the tumor and clip the margin if they are negative. I also do sentinel lymph node biopsy or axillary dissection from the same incision. I also take the partial latissimus dorsi flap from this incision and bring it into the tumor cavity to fill the cavity and fix it to the thoracic wall and pectoralis major muscles. It's cheaper than mastectomy plus implant and takes less time. Cosmetic results are good. And our paper published in 2020 with 317 patients with a good cosmetic results according to EORTC guidelines. And the MELODY study in which we participated and published in last year was a prospective non-interventional multi-cohort study aimed to evaluate the 8 localization techniques of tumors at the time of diagnosis or after NAC, and the study revealed that the successful excision rates of all evaluated techniques were high, but each technique had its advantages and disadvantages. We usually place a marker in the tumor before NAC, use the wire-guided line technique after NAC because it's inexpensive and effective. And evaluation of surgical treatment was stated by Professor Mamounas in the morning. And axilla was considered the most important prognostic factor, but we have more important prognostic factors today. And also axilla was considered to increase the overall survival and decrease the local regional recurrence rate. But we know from NACB-PB04 trials and AMOROS trial and the ACOSOXY11 trial, axillary dissection doesn't add anything about the local regional recurrence or survival advantages, and provided that axillary radiation therapy is added. And then in 1990s, we started to perform sentinel lymph node biopsy, both blue dye and radioisotope. And then after 2000, ACOSOXY11 and AMOROS trials show that axillary dissection were unnecessary even if patients had 1 or 2 positive sentinel lymph node. And after 2010, and especially medical oncologists try to use extensively NAC due to the more effective drugs for systemic chemotherapy and NAC, and we started to see downstaging in most patients with axillary lymph node positivity, and we started to perform marked lymph node biopsy and targeted axillary dissection in patients after NAC. And today we try to eliminate sentinel lymph node biopsy and maybe axillary dissection in marked lymph node positive or targeted axillary lymph node positive patients. In 1980s, professor from Italy did the first CMF trial, and he came to Istanbul. I listened to him. I tried to remember his name. Maybe Mamunos or Kyun name know the name. And he told us after successful CMF trial results, there will be no place for surgeons soon or in future because we will treat all the patients with systemic therapy. But we have place today, and we will have place in future as a breast surgeon. We accept to escalate the role of surgery, but we will have a place to the surgery in future. Today, axillary staging is, I remember Bonadonna. Bonadonna was the master of medical oncology in Italy. Yes, Bonadonna. Okay, today axillary staging is important for systemic treatment selection in patients with ER-positive, HER2-negative premenopausal women, patients with less than 2 centimeter in size tumor, clinical and 0 HER2-positive cancer, not receiving NAC, and triple-negative cancer less than 0.5 centimeter, and post-NAC patients. And nodal status is also currently a major determinant of the use of regional nodal irradiation and post-mastectomy radiation therapy. To stage the axilla, the slide was shown by Professor Kuhn. In patients with clinical and positive disease after NAC has been challenging due to anatomical and biological factors. And FNR false negative rate was 12.6% in ACOSOC Z11. It's 8.4% sentinel node biopsy following NAC trial, and it's 14.2% in Sentinel trial. And it was 13.7% in our prospective clinical trial published in European Journal of Surgery before these trials. And there are many attempts to reduce false negative rate after NAC. Additional evaluation of sentinel node with immunohistochemistry using dual method, removing more than 2 sentinel nodes, marking positive lymph node with different markers and removing after NAC, and targeted axillary dissection, excision of marked lymph nodes, palpable lymph nodes, and non-sentinel nodes. In our prospective clinical trial published in and also Surgical Oncology 2018, 98 patients with T14 and positive M0 breast cancer were included. Biopsy-proven positive lymph node was clipped before NAC, and dual method was used for sentinel lymph node biopsy, and identification rate was 87.8%, and false negative rate was 4.2%, an acceptable rate. And in a systematic review and pooled analysis for marked lymph nodes plus and targeted axillary dissection after NAC, 9 studies with marked lymph node, 13 studies with targeted axillary dissection were included. Post-negative rate was 6.28% for marked lymph node biopsy patients and 5.16% for targeted axillary dissection patients. These FNRs observed are below the accepted target of 10% for clinically proven node-negative breast cancer patients. Our paper published in Cancer last month with the title of Combined Analysis of MF1802, MF1803 Neocentric Studies. The pathologic node positive disease doesn't necessitate axillary lymph node dissection. in patients with breast cancer with a good response to NAC as long as radiation therapy is provided. And 501 patients who achieved complete clinical response to NAC underwent sentinel lymph node biopsy alone and or targeted axillary dissection alone. At a median follow-up of 42 months, axillary and locoregional recurrence rates were 0.4% and 0.8% in sentinel lymph node alone and targeted axillary dissection alone group respectively. And no significant difference was found in disease-free survival and disease-specific survival rates between patients undergoing TAT versus sentinel lymph node biopsy alone, those with breast pathologic response, sentinel lymph node methodology, number of metastatic lymph node, or type of metastasis, micro or macro metastasis. In conclusion of this study, the omission of axillary dissection can safely be omitted, can safely be considered for patients who achieve complete clinical response after NAC, even if residual disease is detected by pathologic examination, provided that adjuvant radiation therapy is administered. Neither the sentinel lymph node methods nor the number of excised lymph nodes affects oncological outcomes. I will shortly explain give about results of our own 209 patients with after neoadjuvant chemotherapy. All radiologic studies performed before NAC were repeated before surgery. Tumors and positive lymph nodes were marked before NAC in all patients. Dual method was used for sentinel lymph node biopsy. Targeted axillary lymph node dissection was performed, and extensive lymph node positivity required axillary lymph node dissection. And Warguide localization was used, specimenography was obtained, and intraoperative evaluation was performed for tumor specimen and sentinel lymph nodes. The tumor cavity was marked and closed by volume replacement or displacement, additional partial latissimus dorsi flap. Mean age was 50 years old, and 63% of patients were premenopausal. Clinical stage was stage 1, 3%, stage 2, 63%, and stage 3, 34%. 11% of the patients had luminal A, 20% had triple negative, and 12% had a pure HER2 positive, and 57% of patients had luminal B plus minus HER2 positivity. And surgery for the breast and the axilla was mastectomy plus axillary dissection in 19 patients, lumpectomy plus sentinel lymph node biopsy in 34 patients, mastectomy sentinel lymph node biopsy in 24 patients, and lumpectomy plus axillary dissection in 23 patients. How about the surgery for the breast? In 26 patients, mastectomy plus implants was performed. Yes, only in 5% of patients had a simple mastectomy, 12% patients had a modified radical mastectomy, and 57% patients had lumpectomy. And the response to neoadjuvant chemotherapy, both breast and axilla, PCR rate was 24%. It was 34% in the axilla. It was 44% in the axilla. It was 34% in the breast PCR rates. And as you see, PCR is lowest in patients with luminal A breast cancer. To my experience and knowledge, we don't do NAC for patients with pure luminal A patient disease. It was unnecessary given systemic chemotherapy for these patients. In patients with HER2 positive, ER positive, PCR rate 36%. It's 44% in patients with HER2 positive breast cancer and 32% in patients triple negative, and overall PCR rate was 24%.
Thank you, Professor Osman. May someone of commentators have a comment or a question from the audience? Thank you, Professor.
We should proceed to the next speaker. Is Professor Karkatsanis, who works at the University Hospital of Uppsala. Andreas, the stage is yours.
Thank you so much. Thank you for the invitation. Now, this is a talk that I'm going to do wearing my editor's hat to discuss a little bit what seems to be a contradiction between what a trial shows, how do we deal with it, and how do we move forward. These are my disclosures, and since this is something for me which is a little bit of a philosophical talk, the first 3 slides have to do with fragments of works of one of my favorite authors, so that we'll just take a minute to sink into them. I'm not going to read them out loud, we'll just have the time to go through them. The next one I like more. And then the last one. So, to proceed to the talk. A trial question is and will always be driven by knowledge gaps that will hopefully inform practice. But more than one trials may examine the same question differently nuanced from different angles. And while trials will accrue patients and evidence to answer a question, the practice will independently proceed and evolve. That means that by the end of a trial, we do have more questions than the answers that we got from the trial. And this means that trial outcomes will always be needed to be interpreted within the trial context when that trial was thought of and with their clinical relevance nowadays. And the bed of Procrustes, since I'm talking to a predominantly Greek audience, should be left out of these types of discussions. So I just sampled a little bit of this and that as an excuse to discuss discrepancies. I got a lot of help, without knowing it, from the talk that Professor Mamounas had this morning. So you will see a repeating theme. We know how the axillary treatment landscape has evolved from the 80s until today. And we kind of understood that it is diagnostic but not therapeutic. And nowadays we are discussing biology instead of stage to inform practice. But especially in the setting of up to 2 macrometastases, we did trials, and there is one more pending, that all examine the same theme with different inclusion criteria, different policies on how to address avoidance of axillary lymph node dissection, and so on. But after these trials, do we have answers for everything? So, how many of you feel that there is adequate level 1 evidence to refrain axillary clearance in the presence of 5 micrometastases? You do not have level 1 data because the micrometastasis study, the IBSCG 2301, said 1 or more micrometastases, but they had no more than 3. They had 1 with 4 that was excluded. Does this mean that we do an axillary lymph node dissection? No, you actually extrapolate from the trial. How many of you feel that we have level 1 data that allows us to avoid completion axillary dissection in a patient with up to 2 macrometastases and a T3 tumor? The Xenomac had 6% only. So it is a subgroup. So formally it is an exploratory analysis, but would we consider doing axillary dissection in a patient like that? No, we just need to acknowledge that limitation. The same thing about extracapsular nodal invasion. It is the exact same thing. And especially about Xenomac, I can say anything I want because I'm not part of the author group. So when I say good things about the study, it is not because I'm part of the author group. Okay. So let's move forward. Omission of axillary surgery for CNO early breast cancer. So let's refine the role of sentinel lymph node dissection for the CT1 and O. Now, you will all think about the sound, but is it really a new thing? We'll come back to that later. And this is the sound. This is how the sound looked like. And this is what they intended to include and exclude. And this is what the primary outcome looked like. Now, the devil's advocate will ask you, is that a new thing? Already from the 90s, you had Roberto Agresti's trial that showed no benefit. And I would go on and argue that it is a very safe bet biologically to say that in a patient that has a unifocal tumor, most probably ER positive, HER2 negative, that has no signs of axillary disease on an ultrasound, giving the whole package of treatment will not probably change the disease, the distance disease free recurrence interval, depending on a sentinel node biopsy conducted or not. In Sweden, there was a prospective cohort study of patients that had been followed, and more interestingly, in this study, we actually knew what happened in the adjuvant setting. So you see that approximately 1/3 of patients got no therapy at all. They just got a lumpectomy, and still things were okay, nothing happened. So that tells us a little bit about the biology, and the Choosing Wisely campaign, you're all familiar with that, has already given us that type of data on an observational level. Now, is it prime time just because of the sound to go further? No, because other trials came and asked us about the axillary status in order to be able to inform systemic treatment decisions, as we discussed. And moreover, we now have more trials that will tell you that it is you could safely omit radiotherapy, the CALGB and the PRIME, for example, or to discuss brachy or partial, if you know that they are node positive pathologically. And with regards to how the sound looks like, because the devil is indeed in the details, 1/3 of patients were actually candidates from the PRIME2 trial. So had you known that they are pathologically node negative, you could safely omit radiotherapy. The other third were patients with very small ER-positive HER2-negative tumors, where you would know that you could even discuss the omission of endocrine treatment in favorable characteristics. So the idea of balancing things is something which is quite relevant, because a 65-year-old patient standing in front of you that is eligible both for the SOUND trial and the PRIME2 trial would optimally, if you want to retain high evidence-based practice, they would have to choose either refraining a sentinel node biopsy but getting whole breast radiotherapy, or the other way around. So there is no clear-cut recommendation for this important cohort of patients. Now, we had this discussion about omitting what I like to call fast-track ALND, and Professor Mamounas alluded to that. There is a meta-analysis from Vivian Mann and Ava Kwong from Hong Kong a couple of years ago that showed that all these patients that had a single pathological node, if taken to fast-track axillary lymph node dissection, you would find that half of them were Z11 eligible. And whilst this is being discussed in the context of clinical trials, and Walters Weber trial is one of those, Shelley Potter got approval for the Tadpole study in the UK now. We are discussing about primary targeted axillary dissection in the context of trials. However, the NCCN guidelines have included that since last year. And I do not believe that a guideline committee would put their money on a not safe bet. This is something that we discussed. You have seen all the numbers. Now, the monarchy misreading of the 4 nodes is a little bit another thing. The 3 types of analysis that you can do in a randomized controlled trial is the per intention to treat, the per protocol or efficacy, and the as treated, right? So the per intention to treat is what the regulatory bodies need to get approval. The efficacy analysis is what the medical oncologist needs to understand how things work and how safe and what do you expect from a drug. We as surgeons treat the as needed, as treated population. We are on the floor, we are working with these patients on a different basis. Now, if I were pharma and I wanted to show that a new drug has got superior outcomes because that new drug would increase costs, I would make sure that my money is on the safest basket. So I would choose the patients that have the highest possible risks to include them so as to make sure that I will show a difference. And this is what happens over here. But is it worth it? You saw the post-hoc analysis from Senomac. You also saw the population analysis from Gaillard from France as well. And that makes a very compelling argument as to whether this is a good idea. And I think it is not. And you could find an alternative, and there are nomograms. This is the most recent, another exploratory analysis from the Senomac, but it is performing completely comparably to previous works, the best of which I think is by Tuomo Meratoja because it was multinational, collaborative, and prospective. And now you've got another choice. And that means that this is not a question anymore. So we had this type of collision in our MDTs with our oncologists, but now, especially now that Ribo got a positive opinion and it's coming into practice, this is a non-issue anymore. And interestingly, for those that were not convinced by the first publication, the most recent publication gives a very clear outcome on how the curves look like. Now, we discussed about that. We know what the observational data looks like. We know what we are expecting, and we know how things are going to move forward. Neoadjuvant endocrine treatment. Do you really have any evidence that suggests that you should subject patients that are still node positive after neoadjuvant endocrine treatment to axillary dissection? In other words, does it behave the same way as the axilla, or does it mean the same things as a still positive axilla following neoadjuvant chemotherapy? I think that we actually know the answer for that. And the issues that we have with neoadjuvant endocrine therapy will probably lead us in dealing with metastatic lymph nodes that will guide decisions as per upfront surgery in these patients. And the most important thing, I think, is that this might be in the future a selection criteria for CDK4/6 in the adjuvant setting. I think that everybody in the room performs or flirts with the idea of oncoplastic breast conservation and immediate breast reconstruction. Do you have any randomized control trials that looked into survival outcomes with this question? No. Will we ever get any? No. And we shouldn't, because that would mean depriving patients of choice. And what I think is that we will move forward to a case where the auxiliary diagnostics will not need to be surgery, and there are different techniques, but I will not go into them. With regards to more surgical questions, in the last decade or so, there has been an explosion of research with regards to non-isotopic sentinel lymph node traces. And this is the primary outcome of a network meta-analysis that suggests that the paramagnetic tracer and ICG perform completely comparable, and you see that the confidence intervals are very, very narrow. So I can tell you that the trial sequential analysis of these trials says that the information size has been saturated. So no more trials will change the outcomes of this. Okay. Now, do you need a randomized control trial? If you go back to the ideal framework, you would need a randomized control trial if superiority claims are made. But if no superiority claims are made, you should not expect a randomized control trial. And given the detection rates that are higher than 98% for the isotope, but these tracers as well, if you wanted to perform a superiority trial, I just did it for the fun of it, you would need a sample size of 32,954 patients. So for everybody that is ambitious, good luck with that. I'm not doing it. And last but not least, breast surgery post-neoadjuvant chemotherapy, it is safe. And we have been debating the question of what we call response-adapted surgery. And we know how things look like, but this meta-analysis of these more historical trials suggested a higher loco-regional recurrence rate. So there were these concerns. I think there are no real concerns, because if one looks to more recent data, this is a meta-analysis on a patient level performed by Antonis Valachis from Sweden, and it shows what are the factors that have to do with loco-regional recurrence, but type of surgery is nowhere inside them. And if you don't like the Swedish data, this is data from Gustavo Berutsky and the German Breast Cancer Group that tells you the exact same thing, the risk of loco-regional recurrence. And if you're not very fond of the German data, this is the I-SPY 2 trial data that shows the exact same thing. So what that means is that your risk of recurrence may depend on many things, but type of surgery offered afterwards is not one of them, provided that you have clear margins. Now, this is a problem because complete pathologic response and BCT do not seem to correlate. And in a previous work that I did some years ago, what we saw in trials that included surgical intention at baseline and following neoadjuvant chemotherapy, there was no correlation between overall complete response, which is what you know before surgery, and shift to breast-conserving surgery. And when one was looking at that, you could see that primary systemic therapy doubled the eligibility. Only 70% of those actually got it, and that was not a significant effect in terms of conversion. But it is not reasonable, because what these two forest plots show you is that approximately 69% of patients that could undergo breast conservation and had an at least 50% reduction of the tumor size received mastectomy. And when you were looking at the patient's type of surgery and path CR, 6 patients that were eligible for breast conserving surgery and had path CR actually got a mastectomy. And, well, do we expect a randomized control trial on this outcome? We are blaming it on the fact that neoadjuvant trials do not include surgical oncologists. But this is a problem, because we are doing it, we know it works, And there will not be an RCT with these questions because, again, it is a matter of ethical regulation and approval. A tumor has disappeared, you cannot, or has, shrinked. You cannot possibly tell a woman that I would like to randomize you to a mastectomy or to breast conservation just because I'm curious about something. And that was me. Thank you very much.
Thank you very much, Andreas. Any questions or comments?
Thank you for the excellent talk. Actually, it was something I was not expecting to hear in a Congress, but I think it was very interesting. My impression is that we know where we're heading, and we're designing studies to prove our practice most of the times. And I think there are many unanswered questions because the practice have already been established, and then you can't really make a study to prove that. And on the other hand, there are studies that when they were designed, they were not expecting that other data. For example, the SOUND trial was very unlucky because when the SOUND trial was designed, was not expecting that the monarchy was going to come up and other studies in between. So I think there are some studies that they are lucky and some other studies that they are unlucky. But at the end of the day, I think the practice is determined before we design the studies. What is your opinion about that?
I would agree. I would not call them lucky or unlucky. What I think is that we get a fuller piece of the big picture, but the pieces of the puzzle are not put on the picture on a linear fashion. You get separate bits and bytes here and there. We are discussing about omitting sentinel lymph node biopsy on these patients, for example. At the same time that the SOUND was recruiting, in Italy, they are performing 57% sentinel lymph node biopsy in patients that have in the end pure DCIS. So you see my point. We are discussing about where the spaceship will go, but we need to sort things on a completely different level when it has to do with informing clinical practice. The big challenge is how to adjust our interpretation of trial results today based on the understanding that this was a concept conceived 10 to 15 years ago. That's the big question. And where do you put a stop? Like, I have a question for the audience. How many of you know how many randomized controlled trials established the superiority of total mesorectal excision for rectal cancer? What is the evidence behind these? None. There are 2 monographs by R.J. Hild. 2 monographs. And that established practice. So we need to think on a pragmatic level when we are discussing these types of things. And we just need to prospectively audit, register, and understand what we think. The randomized control trial will always be the golden standard in terms of efficacy comparators if you want to produce an explanatory trial and provide inference. But the big question is, when do we actually need inference? If Aksana had been a randomized control trial, they would have been able to put the power around one endpoint, right? Yeah.
Comments by Professor Kuhn?
Andreas, I have another question. So you are from Sweden, but not among the authors team of Xenomac. Is Xenomac confirmation of Z11 or confirmation of Amaros?
Amaros.
Yes, thank you. Now, question
because, excuse me for interrupting, for the people that don't know the background, the initial intention for Xenomac was to omit radiotherapy. And whilst we were recruiting, there were national but also international objections from radiation oncologists, and this is why the New England Journal of Medicine did present the per protocol analysis. So what Xenomac tells you is that beyond doubt on terms of an adequate sample size, auxiliary radiation therapy can replace lymphadenectomy, regardless of type of surgery that you have performed.
Yeah. And this leads I think it's important discussion. This leads to an important discussion in Germany. So with Z11, according to protocol, there were tangents. Then we learned analyzed from JAXI that there were many patients with high tangents. So we introduced high tangents in our guidelines, whole breast irradiation and with the target volume until the lower border of the axillary vein. Now with Xenomac, 90% had whole regional irradiation level 1, 2, 3, 4. Now what happens in our country is that radiation oncologists say, okay, so far we irradiated high tangent, but now we have best evidence from Xenomac to go even further. Now with Xenomac we extend radiation therapy.
That's an interesting comment. Last week I was giving a keynote lecture to Denmark about the management of the axilla. So their concern was the Lancet Regional Health paper, Tuve's paper from Xenomac. And now they know how high a percent of patients will have more nodes because of the control arm. So the medical oncologist, what they say is that to be on the safe side, if you don't want to clear the axilla, we will give 2 more cures of chemotherapy, not dose dense, which I would understand, but they just prolong. So they are buying 2 on the house. And that's also another thing that we need to account for, because cumulative knowledge will bring new questions and uncertainties in how to deal with these scenarios. And we need to be aware of that. And we need to just make our decisions in common sense. Eric Weiner has said one of the things that I think of more and more in my practice. Do you ever get the perfect trial that will give you the answer to all of your questions? No. You just need a reasonable subgroup in order to make safe extrapolations.
Any other comments or questions?
Oh.
Michailis Kondos.
Γεια σας, γεια σας. No. I recruited for the Xenomac.
But you still don't like it.
Oh.
Anyway, we can go
I have been defending Xenomac more than I defend my own trial. So.
Okay, we can talk about it later. But now I want to say something. I'm not sure whether we agree or disagree. Extrapolating conclusion from a big trial to a smaller group is part of is so attached, so closely connected to randomized control trials for as long as they exist. I mean, when you design a randomized control trial, you know that your population will be people with quite different tumors, and but in the end you have to come up to one conclusion. And if the trial is from there to there, this patient here is very different to that one, but still you come up to a conclusion for all of them.
I agree.
And what applies to this one may not apply to this one. And what is even more important is if you stick to the 2 trials you mentioned before, Z11 and Amaros trial, despite the fact that both of them were underpowered and they stopped before they reached power to prove what they wanted to prove, we took despite the fact that the patients recruited in these trials are patients with very minimal axillary burden, we use the results for people who are much higher axillary burden in the axilla with time.
And this is how things will go. In the morning, Professor Mamounas showed the rate of more metastases on the control arm of these trials. And the newer the trial, the higher the percentage, which suggests that we dare to go more and more and more and more.
It will be impossible to have a randomized control trial for each one of the small
I agree.
Group.
I agree. But what I'm just saying is that in terms of methodological intactness, the main criticisms around Z11 were, subtypes, underpowered, not enough events, this, that. But the growing field of interest, if you apply the Z11 criteria in the patients of the trials that followed the Z11, you will see that the saturation level is at least 88%. That's my point. The point is that you will always apply data that are in subgroups that have been described, regardless of whether they have been adequately recruited for. And this is why I think that once you know the robustness of the results, and this is what, if we're talking CENOMAC, this is what CENOMAC did. CENOMAC put the tombstone over the doubt for axillary lymph node dissection.
But it took it 10 years to do that.
Yes.
And these were the importance of registry trials or non-interventional trials come in. I think this is where the importance of Axana comes in.
Exactly.
Because it collects a large number of people very quickly, relatively quickly, and will have, I hope, will have enough power for each one small subgroup to draw safe conclusions. And furthermore, it is real world data, not marathon runner,
I
patients.
agree. I'll just say that to conclude. The LORD trial from the Netherlands was looking at the question of monitoring versus active surgical treatment for low-risk DCIS. That trial was running for 4 years as a randomized control trial, and they had included 72 patients. So they made it a patient preference study. And from the 4th to the 5th year, they went to 770 patients. And I do not think that the value of the results for clinical practice will be reduced because it is a non-randomized study now.
Any other questions? Okay, so a closing remark from Yannis.
Okay, I have to thank all the presenters for the excellent presentations. The most of them are here from the morning, so great thanks. Thank you very much.